Hi everyone, thanks for tuning in to this part 1 training video for the new PPO 680 Opioid Withdrawal Orders. This video is specifically going to talk about the medication buprenorphine naloxone that is indicated for patients who have opioid use disorder, and it's going to talk about the clinical aspects of the medication, monitoring, things like that. Part 2 training video is going to specifically talk about the order set and the logistics of working through that order set. Just to quickly introduce myself, my name is Jackie and I am a pharmacist and I work with the Opioid Stewardship Program. Buprenorphine naloxone, also known by its brand name Suboxone, is used in the treatment of opioid use disorder. It works by relieving and preventing opioid withdrawal symptoms and cravings, resulting in a reduction or cessation in the use of other more problematic opioids. Because it is safer and better tolerated than methadone, it is now considered first-line therapy for most patients. Currently in Canada, buprenorphine naloxone is available as a sublingual tablet. A sublingual film has also been approved for use. That just happened in summer 2020, but it hasn't yet been marketed, so it's currently not available. The tablet contains 2 different medications, the first being buprenorphine, which works on the opioid receptors to treat opioid use disorder, and the second being naloxone, which is present only to prevent diversion or misuse of the medication. Just to quickly touch on opioid use disorder, research in this area has expanded in recent years, and we now recognize it as a long-lasting disease of the brain that causes significant impairment in a person's life caused by the cumulative effects of opioids on the brain. Opioid use disorder can involve the misuse of opioids that are prescribed to a person, opioids that have been diverted from a person they were originally prescribed to another person, or it can involve illicitly obtained opioids. Unfortunately, opioid use disorder doesn't end after a period of abstinence when the opioid is removed from the body. Like other chronic diseases, it requires long-term disease management and may involve many cycles of drug use, reduced use, or maybe even abstinence, and then potentially return to use. The first medication in this tablet is buprenorphine. Buprenorphine is an opioid. However, it has unique pharmacology that makes it superior to methadone for safety and tolerability with comparable treatment outcomes. In the body, there are different kinds of opioid receptors. The mu receptors are responsible for the analgesic effects of opioids, as well as causing depression, euphoria, physical dependence, respiratory depression, and sedation. Buprenorphine is a partial agonist at these receptors, meaning it binds to these receptors, but it doesn't stimulate them as much as other opioids, such as methadone or hydromorphone or fentanyl. You can think of this as a light bulb on a dimmer switch. Full opioid agonists, again like methadone or fentanyl or morphine, cause the light bulb to burn very bright and hot, where buprenorphine doesn't light up that light bulb quite as much. This provides many benefits, such as less euphoria, less side effects, and most importantly, less risk of overdose. Buprenorphine also binds very tightly to the opioid receptors. This is called high affinity. If 2 opioids are present in the body, most of the time buprenorphine will win out and take over the receptors. Because of this tight binding, it means that buprenorphine is very long acting. The onset of action is usually within 30 minutes, and suppression of withdrawal symptoms and cravings should last a minimum of 24 hours when dosed appropriately. Buprenorphine is hepatically eliminated, so liver enzymes are recommended to be obtained prior to initiation, and we want to be cautious for use in those with liver failure. It is safe to use in those with decreased renal function. The second medication in this formulation is naloxone. Naloxone is an opioid antagonist, which means it has the opposite effect at the receptors and is used to reverse opioid overdose. It's also known by the name Narcan. However, when naloxone is taken orally or sublingually, it gets inactivated by the liver and it doesn't enter into systemic circulation, and therefore it has little to no activity. Naloxone is only present in this formulation to prevent misuse of the tablets, and that can be either by crushing and injecting or snorting. There are 4 strengths of tablets available: buprenorphine naloxone 2 milligrams, 8 milligrams, 12 milligrams, and 16 milligrams. And it's common for the tablets to be referred to by the buprenorphine component only. So that's that first component: 2 milligrams, 8 milligrams, 12 milligrams, or 16 milligrams. The naloxone is always present in a 4-to-1 ratio of buprenorphine naloxone. As for administration, buprenorphine naloxone is a sublingual tablet that must be dissolved under the tongue. This can take anywhere from 2 to 10 minutes, but maybe even longer in some people. Wetting the mouth with a cool drink prior to administration may help speed up this process. It is really important that the person doesn't eat, drink, smoke, or vape during the administration and for at least 5 minutes afterwards. So that whole process could maybe take around 30 minutes depending on the patient. If the tablet or any parts of the tablet are swallowed while it's dissolving, the bioavailability will decrease to less than 10%. So this means we'll get less effect from the medication. This is a common medication error and can lead to continued cravings or even continued opioid use. So we want to make sure that patients are aware that it needs to fully dissolve in the mouth. Side effects of buprenorphine naloxone are similar to other opioids and include things such as nausea, headache, and constipation. They are usually mild and can be managed with simple interventions such as avoiding administration on an empty stomach or with certain over-the-counter medications. To compare buprenorphine naloxone to methadone, when dosed appropriately, buprenorphine naloxone doesn't significantly differ from methadone in terms of treatment retention. Doses of buprenorphine naloxone greater than 16 milligrams have been shown to be comparable in effectiveness to 60 to 100 milligrams of methadone, but also to have improved safety. Buprenorphine has a lower potential for respiratory depression, and standard doses that we see for opioid use disorder are well below the threshold lethal dose for an opioid-naive adult, compared to standard methadone doses, which often exceed the threshold lethal dose. Other studies have found that methadone has a 4-fold higher risk of fatal overdose and a significantly higher risk of non-medical or other problematic use compared to buprenorphine. Furthermore, methadone has a higher potential for adverse drug-drug interactions with many common medications such as antidepressants, antibiotics, or antiretrovirals, as well as increased risk of cardiac arrhythmias as a result of QT prolongation. So it's for many of these reasons, especially the safety profile, that buprenorphine naloxone is now considered first-line therapy over methadone. We're now going to get into the steps for initiating this medication. This process is generally known as induction, so you'll hear me use that word quite a bit. So day 1, prior to the first dose of buprenorphine naloxone, the patient must be in at least moderate opioid withdrawal. This is to prevent an important adverse effect known as precipitated withdrawal. Precipitated withdrawal is a state of acute and severe withdrawal symptoms that occurs when the first dose of buprenorphine is taken while other opioids are still present in the body. This only happens after the first dose and usually occurs within 30 minutes of administration. The reason this happens is because buprenorphine binds very tightly to the opioid receptors. And if another opioid, such as morphine or fentanyl, is present, buprenorphine is going to knock it off the receptors and take its place. This is problematic because buprenorphine doesn't stimulate those receptors as much as other opioids. So this results in a rapid decrease in the net opioid effect and severe sudden withdrawal symptoms for the patient. Again, you can kind of think of it as a light bulb. Opioids such as fentanyl or methadone cause this light bulb to burn very brightly. But if buprenorphine is introduced, it's going to push that other light bulb off fit into the light socket, but it's not going to burn as bright or as hot. So it's like rapidly dimming the lights on that with that dimmer switch. Overall, less opioid effects equals withdrawal symptoms for the patient, and these are much more severe and distressing withdrawal symptoms compared to just kind of naturally withdrawing off an opioid. While generally not harmful, precipitated withdrawal can be quite distressing and cause a negative experience with buprenorphine naloxone, which can potentially impact the success of future treatment. The best treatment for precipitated withdrawal is prevention. We want to make sure that an appropriate time frame has elapsed since the patient has last used or taken opioids. So for short-acting opioids such as hydromorphone, morphine, or heroin, we want to wait at least 12 hours. For longer-acting opioids such as hydromorphcontin, oxyneo, fentanyl, or Cadian, which is slow-release oral morphine, we want to wait at least 24 hours. And for methadone, at least 72 hours or 3 days. We also want to make sure the patient is experiencing at least moderate withdrawal symptoms. We can determine this using the clinical opioid withdrawal scale, which you can see on the screen there. This is also known as the COWS scale. The COWS scale is administered by a healthcare provider and assesses a combination of 11 objective and subjective withdrawal symptoms. It involves taking a resting pulse, examining the pupils for dilation, observing for tremor and restlessness, as well as asking about bone or joint aches and symptoms of anxiety or irritability. Each symptom is given a score based on its severity. Once the total COWS score is added up and greater than 12, and the appropriate amount of time has elapsed since the last dose of opioid, then it is safe to give our first dose of buprenorphine naloxone. And there is a link there to a YouTube video of a nurse providing a COWS assessment to her patient. Unfortunately, if despite our best efforts, precipitated withdrawal does occur, there are 2 options for management. Both options involve explaining to the patient what has happened and offering lots of support and reassurance. Again, precipitated withdrawal can be quite distressing, but it's generally not harmful. Medications to manage withdrawal symptoms should be offered. These include clonidine for symptoms like restlessness and tachycardia, acetaminophen or NSAIDs for aches and pains, and making sure we're providing symptomatic management of nausea and diarrhea. If the patient consents, it is preferred to keep going with the induction, and so we want to provide additional doses of buprenorphine naloxone every 1 to 2 hours until the symptoms of withdrawal subside. The patient may also decide to not continue, and then we can arrange for a trial at a later date if they're willing. Note, it's really important to avoid the use of benzodiazepines for the management of opioid withdrawal symptoms and during buprenorphine naloxone initiation, as benzos in combination can lead to increased risk of CNS depression, respiratory depression, and overdose. So back to this day 1 initiation flow diagram. Once we've ensured that an appropriate time has elapsed and the patient is in moderate withdrawal based on a COWS score of greater than 12, the first dose of buprenorphine naloxone can be administered. This is usually a 4 milligram dose dissolved under the tongue. Within 30 to 60 minutes, another assessment of withdrawal symptoms occurs. If the patient's withdrawal symptoms have remained the same or gotten better, a second dose of buprenorphine is then provided. Dosing can continue based on withdrawal symptoms to a maximum dose of 12 milligrams on the first day. If withdrawal symptoms significantly worsen after the first dose, then we should suspect precipitated withdrawal. On day 2 and onwards, the daily dose can be increased, usually by 4 milligrams, if the patient is still experiencing withdrawal symptoms that morning. A therapeutic dose is one that manages withdrawal symptoms and cravings for a minimum of 24 hours without causing troublesome side effects. In Canada, the maximum daily dose is 24 milligrams. However, buprenorphine naloxone may be prescribed off-label to the manufacturer recommended daily max of 32 milligrams. So that's the quick tour of buprenorphine naloxone. In summary, we know that it's the first-line therapy for management of opioid use disorder, and it suppresses opioid cravings and withdrawal symptoms for at least 24 hours and is generally safer and better tolerated than methadone. It's a sublingual tablet. Tablets must be dissolved under the tongue for the medication to be effective. This may take up to 10 minutes or longer, and patients should remain NPO during and for at least 5 minutes after administration. It's also extremely important that our patients are in withdrawal prior to the first dose. We make sure of this by ensuring that an adequate time has elapsed since their last opioid dose, usually 12, 24, or 72 hours, depending on what their last medication or drug use was. And we want to make sure they're having withdrawal symptoms, so their COWS score is greater than 12. And management of precipitated withdrawal involves reassurance and as well as medications to relieve symptoms. I also wanted to provide some resources in case someone wanted to do a little bit more learning on their own. There is this buprenorphine naloxone in acute care pamphlet. If you don't have it, you can ask your nurse educators, and if they don't have it, they can contact the Opioid Stewardship Program to get some copies. The College of Physicians and Surgeons has their own guidelines and standards for opioid agonist therapy, so it's a very comprehensive guide. There's lots of information in there. RX Files has an opioid use disorder opioid agonist therapy chart that can be found online. And then one good free online learning program that doesn't take too much time, it comes from McMaster University, and that's the Mac Health Clinical Opioid Primer. And so they have one module that's initiating buprenorphine in primary care, the emergency department, and inpatient settings. So if you're looking to do some more learning on your own, I would suggest that one as a potentially good start. So thanks for your time. Again, video number 2 is going to talk about more of the nitty-gritty with the order set. Thanks.